Welcome, and thanks for joining today as we talk about taking a deep cleansing breath, update in the management of chronic rhinosinusitis with nasal polyps. I'm Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia. And these are my disclosures for this particular lecture. We have three learning objectives that we're going to cover today. One is we're going to analyze the different phenotypes and endotypes of chronic rhinosinusitis with and without nasal polyps based on what is understood thus far about the immunologic pathophysiology and its impact on the disease burden. We'll also summarize the mechanisms of action of new and emerging targeted biologics for our patients suffering with chronic rhinosinusitis with nasal polyps, as well as their efficacy and safety revealed in clinical trials. And lastly, and very importantly, how to implement shared decision-making with our patients that suffer with chronic rhinosinusitis with nasal polyps to determine when a biologic or surgery or another treatment is most appropriate for them. First, we have some pre-test polling. So we want to get your answer. And at the end of the program today, I'll be going back as we do a post-test and look at the answers. So the first question, the primary cytokines involved in type 2 inflammation, the most common endotype in patients with chronic rhinosinusitis with nasal polyps are interferon gamma and IL-12, TNF alpha and IL-6, IL-4 and IL-13 and IL-5, and IL-17 and IL-2. Please submit your answer. The next polling question. Which biologic showed improvement in nasal polyp score by 2 points or greater in close to half the patient population at 24 weeks and 52 weeks? Was it the phase 3 study with benzarilumab, Dupilumab, mepolizumab, and omalizumab? Your answers, please. Third question, which is the most commonly observed treatment-emergent adverse event across the clinical trials of all biologics that have been studied so far in our patients with chronic rhinosinusitis with nasal polyps? Is it epistaxis, injection site reactions, nasal pharyngitis, or abdominal pain? The next question, Mr. Brown, a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps, returns 12 months after endoscopic surgery complaining of persistent symptoms. You suspect nasal polyps have regrown as type 2 inflammation is a predictor of polyp return in over 50% of cases. Disease scoring systems show some improvement, but do not meet the euphoria criteria for adequate response now. What does euphoria recommend now for this patient? Is it return to medical management and short course of oral corticosteroids, biologic drug or revision surgery, exhalation delivery device with fluticasone, or corticosteroid eluding implantable stent? And our next question. Feeling discouraged, Mr. Brown says, if the nasal polyps are just going to come back anyway, he doesn't want to go through an expensive pain and downtime of undergoing surgery again. Shared decision-making means the best action now would be, 1, to advise him to reconsider surgery because greater than 30% of the patients do require repeat surgeries. appraise him that the guidelines recommend and ask him to decide between the two options, give him information about all available biologics and ask him to choose one, and then letting him know all his therapeutic options and the pros and cons of each. Okay, so let's look, in fact, as we start, look at a case study. So here we have Bob. Now, Bob's a 45-year-old who comes to us with chronic rhinosinusitis with nasal polyps. Now, he has an asthma comorbidity, and he says that his polyps have really gotten worse over the last 2 years. He's required multiple oral corticosteroid bursts for this problem over the last couple of years. He tells us that he's very compliant with his standard of care management of saline irrigation and intranasal corticosteroids. He says his sleep quality and work productivity and social life have really been negatively affected with this condition. And he tells us he's never had any type of sinus surgery. So here's our polling question. What additional information would you consider most important at this point? Blood eosinophil count and serum IgE, CT scan of the sinuses, nasal endoscopy, spirometry, or fractional exhaled nitric oxide? So if we look at the answers so far, what we saw here was in fact the most probably important answer because of his chronic rhinosinusitis with nasal polyps is in fact is objective measure. So that would be a CT scan of the sinuses to look at the paranasal sinuses, or in fact, very importantly, endoscopy that'll also give us an idea of the polyp size. Now, the other answers are important related to Bob because he does have asthma, and things like blood eosinophils and serum Ig are important biomarkers to help us determine, in fact, if he has type 2 inflammation. The same thing goes with the fractional exhaled nitric oxide. As far as spirometry, I mean, that can help us to see how well his asthma is under control, as we know that patients with chronic rhinosinusitis with nasal polyps, in many cases, have more severe asthma condition. So, in fact, all of these can be very valuable when working up Bob. So let's now look at an overview of chronic rhinosinusitis. And one of the things I think we're all aware of that manage these patients is this is a very common condition. In fact, it's estimated that over 11% of the US population, in fact, suffers with chronic rhinosinusitis. And we tend to divide it into two large groups, those with and those without nasal polyps. Those without nasal polyps, in fact, make the largest group, about 80% of the sufferers, and it's predominantly seen in females, where the group with nasal polyps then is about 20% of the total. And again, there tends to be more of a male predominance in that particular group. Very importantly is to understand that this is really a worldwide condition. So this study that I'm showing you from Backard, where they looked at studies that have been done in other countries, looking at the prevalence rate of chronic rhinosinusitis with nasal polyps. And you can see, in fact, here, Brazil at 5.5, in Europe almost 11%, and China being at 8%, a little bit higher in the US. But the point being is this is a worldwide condition that leads to suffering in the patient population. Also, very importantly, is understanding that this is a high-cost condition. So this is a very interesting study that was published in Laryngoscope back in 2019. And they looked at data from a large claims-based database of over 21,000 patients, basically half with chronic rhinosinusitis with nasal polyps and a control group of patients, in fact, without. Now, these dollars were looked at over about approximately about a decade ago, but I think it's still very relevant, and probably it's even much higher at this point in time. But if we look at the total cost in blue for the group with chronic rhinosinusitis with nasal polyps, you'll see it's about $19,000 per year, where in the group without, it's about $7,500. So you see that IC or incremental difference in annual cost being over $11,500. And for all of these, pharmacy, medical, office visit, ambulatory costs, you can see a much higher rate of cost in our patients suffering with chronic rhinosinusitis with nasal polyps. Now, very importantly, as we talk about the subject, we need to understand the diagnostic criteria and also, very importantly, the comorbidities. So the diagnostic criteria that is pretty standard throughout the world is the clinical criteria that patients need to have at least 2 of these symptoms for 12 weeks or greater to be classified. And that includes mucopurulent drainage, nasal obstruction or congestion, facial pain, pressure fullness, and decreased sense of smell. And then very importantly, and we talked about this with Bob, is having objective criteria. At least one of these tests, either endoscopy to look at the presence for polyps, or a CT scan of the sinuses to document the degree of inflammation of the paranasal sinuses. Now, what we have here is looking at the disease burden and the 4, again, major symptoms. And what I wanted to make the point here, and I think this is important in our clinical practice, is if we look at the group without polyps, probably the most important symptom that we hear a lot of from our patients is that facial pain and pressure. Again, they can have the other symptoms. Classically, in our patients with chronic rhinosinusitis with nasal polyps, is that decrease or loss of sense of smell. That really causes a lot of quality of life issues for our patients. And if you look at the CT scan here, under severe chronic rhinosinusitis or nasal polyps, again, you can see almost pansinusitis in this particular patient. And just below that with endoscopy, you can see the large grape-like pale lesions that in fact are the large polyps that this particular patient has. Now, much like we do in asthma, we talk about uncontrolled disease. So what is uncontrolled and what is severe chronic rhinosinusitis with nasal polyps? So this comes to us from the Euphoria group. Now that's the European Forum for Research and Education in Allergy and Airways Disease. And this was recently published in the Journal of Allergy and Clinical Immunology. So uncontrolled disease is persistent or recurrent chronic rhinosinusitis with nasal polyps, despite the use of long-term intranasal corticosteroids and having received 1 or more bursts of oral corticosteroids in the preceding 2 years or a previous sinonasal surgery. So if you think about this, there's no doubt that Bob, our patient, in fact, does fall under uncontrolled disease. And what do we mean by severe? So this is bilateral chronic rhinosinusitis with nasal polyps and a nasal polyp score of 4 or greater. And we'll go over this later, but the bottom line is the highest score would be an 8. So again, 4 or higher is significant here, and persistent symptoms despite long-term intranasal corticosteroid use with the need for add-on therapy. And my guess is, though we have not measured or looked at the size of Bob's polyps, there's probably a high likelihood, especially with his quality of life problems, that he probably does have a score of greater than 4 and probably also fits under the severe category. Very importantly is to understand comorbidities that are associated in our patients with and without nasal polyps. So this is an interesting study by Batra. This comes out of the University of Texas Southwestern. These were patients that were referred to their ENT clinic and also to other academic ENT clinics around the United States for revision sinus surgery. And so what they looked at is their groups with and without nasal polyps and looked at the different comorbidities. So if we look first at aspirin or NSAID, exacerbatory respiratory disease, you can see none of the group that did not have polyps, none of them had that problem, 28.3% of the group with polyps. If you look at asthma, the group without polyps, 22.4%, much higher in the group with polyps with asthma at 68.5%. And then you see the same type of increase with polyps related to allergic rhinitis. So very importantly, and as we'll talk about, we know that these in fact are type 2 conditions that we see in fact so commonly in our patients that are suffering with chronic rhinosinusitis with nasal polyps. Now, the other thing that I think is very key here, especially as we talk about Bob, is that in general, when you have nasal polyps, you tend to have poorer control of your asthma, and you tend to have more asthma exacerbations. So if we look at the table on the left, this is a study out of Montreal, looking at patients with asthma that did or did not have nasal polyps. And as you can see here, the group with nasal polyps was older, had poorer lung functions, higher levels of serum and sputum eosinophils, higher doses of inhaled corticosteroids to try to control their problem, and poor asthma control. And then if we look over at the right, this is a study from the Severe Asthma Research Program looking at the relationship in the adult population of nasal polyps and the number of asthma exacerbations per year. And what you can see here, in fact, this was statistically significant, that in fact, patients that had 3 or more exacerbations had significantly higher level of patients with nasal polyps than with 1 to 2 exacerbations or no exacerbations. Also, very importantly, when we're taking care of these patients is to determine, in fact, if they have aspirin or NSAID exacerbatory respiratory disease. Because, in fact, in our patients that have chronic rhinosinusitis with nasal polyps and asthma, approximately 30%, in fact, have aspirin or NSAID exacerbatory respiratory disease. And the reason that's so important to know is that these tend to be some of the most severe patients that we take care of with asthma and nasal polyps. Especially in the asthma population, these tend to be much more difficult to treat. They are at a higher risk of death, many hospitalizations and ICU visits. And the patients, as far as with their polyps, they tend to be very full of eosinophils, and these patients usually have very large polyps leading to decrease or loss of sense of smell. So many times from the history, we can determine, in fact, if the patient has a sensitivity to aspirin or NSAIDs. Unfortunately, there is no blood test to diagnose this, and sometimes we may have to do an oral challenge to determine if, in fact, the patient has this condition. Now let's move on and talk about inflammatory endotypes and talk about the pathophysiology of chronic rhinosinusitis with nasal polyps. So we can divide this into 3 inflammatory endotypes. Type 1, you see the effector cells here, where the cytokines that drive this is interferon gamma and IL-12. This is predominantly seen in patients with chronic rhinosinusitis without nasal polyps, again, higher in females than males. Type 2, which we're familiar with the different effector cells, including eosinophils and mast cells and Th2 cells, and the primary cytokines which drive type 2 inflammation, IL-4, IL-5, and IL-13. Again, these patients have the highest rate that we see of nasal polyps, especially in the Caucasian and African American population. Obviously, they have a high rate of asthma, as we mentioned, and a high problem as far as decrease or loss of sense of smell. Now, the third group, in fact, is type 3, which is primarily neutrophilic, driven by IL-17 and IL-22. They have a lot of purulent drainage. It's seen with chronic rhinosinusitis without nasal polyps. It's also seen in the Asian population, in fact, with nasal polyps. So if we look at the differences between the 2 main phenotypes for chronic rhinosinusitis, again, without polyps is primarily a type 1 reaction. And again, the comorbidities of asthma, allergic rhinitis, and aspirin or NSAID exacerbatory respiratory disease are less than the group with polyps, where in fact the predominant inflammatory profile, as we know, is type 2 disease. Now, let's take a little deeper dive in the activity of the type 2 cytokines as they play a major role in the development of chronic rhinosinusitis with nasal polyps. And we can start, and as we know with asthma and atopic dermatitis, there is definitely epithelial barrier activation and dysfunction, We know that there can be abnormalities or deficiencies like flagellin in the tight junction proteins that bind the epithelial cells together. We know that the epithelium gets bombarded with allergens and bacterial antigens and viruses, and especially with the condition of nasal polyps, many times we will have bacterial colonization related to Staph aureus and biofilm production. It's important to note that the epithelium is active in itself with the release of epithelial alarmins, such as TSLP, IL-25, and IL-32, which can drive type 2 inflammation through the type 2 innate lymphocyte. Also key is understanding that the T null cell here in a environment with IL-4 can become a Th2 cell. That Th2 cell that can release IL-4, IL-5 and drive B cells, in fact, to become plasma cells to produce IgE. And in many of our patients with chronic rhinosinusitis with nasal polyps, it can be many different allergens that can drive this, including Staph aureus superantigen. As we can see here, then that IgE then binds to mast cells and basophils, and then on re-exposure to that allergen, we know that the mast cell can erupt and release hundreds of different types of inflammatory mediators like histamine, the leukotrienes, prostaglandins, and also very importantly, a positive feedback of IL-4, IL-5, and IL-13. Very importantly is the role of eosinophils and eosinophilic inflammation. And we know in the bone marrow, IL-5 is important for stem cells to differentiate into eosinophils. And also IL-5 is very important for survival of eosinophils in the circulation. Now, once we get to the target organ, here we're talking about the nasal sinus tissue, then in fact, we know that both IL-4, IL-5, and IL-13 are important as far as upregulation of adhesion molecules and therefore chemotaxis of the eosinophils into that tissue. And we're starting to learn a lot more about the role of IL-13. We know it has a major effect on epithelial cells with, in fact, increased mucus production and goblet cell hyperplasia, and an effect on the fibroblast. And with changes, in fact, of the epithelium, you get increased collagen production, fibrosis, and it appears also to have a very important effect as far as increasing of polyp formation. So let's go back then to Bob here. As we mentioned, as far as his medical history, he's 45. He has chronic rhinosinusitis with nasal polyps. If we look at his lung function, he has an FEV1 of 68% with a 17% reversibility. So he does have asthma, doesn't look like it's under very good control. And his fractional exhaled nitric oxide is elevated at 35 parts per billion. He tells us he has no problems or worsening when he takes aspirin or NSAIDs. He's had 2 courses of oral corticosteroids in the last 2 years. For his asthma, he's on high-dose inhaled corticosteroids, long-acting beta agonists. As we already mentioned, for his nasal polyps, he's on nasal saline irrigation and intranasal corticosteroids. So we have another question for you. Excuse me. What treatment would you recommend for Bob? Would it be a functional endoscopic sinus surgery or FES, biologic treatment, exhalation delivery device fluticasone, or alternate day oral corticosteroids? So if we look at the answers here, it looks like it's primarily biologic treatment with next coming a surgery. And again, in fact, all of these treatments could be recommended to Bob. I think that when we talk about shared decision making and we let him get involved in the process, we can see which direction Bob would like to go in. So with that, let's move on now and talk about treatment of our patients, and we'll start with medical management. So as we mentioned, there's standard of care medical management. This is what we start all our patients on with chronic rhinosinusitis and with nasal polyps. So saline irrigation, and I think what the clinical studies really show that daily large volume irrigation is the best, especially being hypertonic. We know that low volume really has minimal improvement. The standard of care, of course, has been intranasal corticosteroids. And again, we usually use twice the recommended dose that we use in the treatment of patients with allergic rhinitis. In other countries, we do have approval for different nasal steroid installations and drops, but none approved in the United States, though there is the off-label use in patients of budesonide respules. And then oral corticosteroids, which we use at times for acute relief of severe blockage and loss of sense of smell, what many of us call a medical polypectomy. Obviously, we want to limit this as much as possible because of the possibility of corticosteroid side effect. What we do know, for some patients, standard of care management will work, but in many other cases, it's a short-term response, and we see a significant failure rate in our patient population. So where do we go from there? So one treatment that was approved in 2017 is exhalational delivery system with fluticasone. So this is a device that delivers fluticasone, but as you can see here, it has a place where you put your nose and also your mouth. So what you do is you blow into, in fact, the device. That then leads to your soft palate closing. Then when you do spray with the other nostril into the nose, that increases the pressure because of what you've done to the soft palate, raising it up. You increase the pressure and therefore hopefully allows for more penetration of the fluticasone, the intranasal corticosteroid, back to the posterior sinus cavity. Now, in their phase 3 study with over 300 patients with moderate to severe chronic rhinosinusitis with nasal polyps, they found that the polyps were completely eliminated in 25% on at least one side by week 24 versus only 8.7% in the placebo. They also used the SNOT-22 or the sinonasal outcome test, which looks at symptomatology and quality of life. They showed significant improvement there and also a significant decreased need for surgery. Which then leads us to one of the treatments, and that is functional endoscopic sinus surgery. And there are definitely pros and cons that we need to understand, our patients need to understand related to sinus surgery. It can lead to very rapid relief of symptoms, and the success rate as far as acutely for these patients is high, 80 to 90%. And in general, this tends to be described as minimally invasive surgery compared to conventional sinus surgery in our patient population. So therefore, there is more rapid healing. Patients tend to recover faster. It can be done on an outpatient surgical basis. In general, there are fewer complications. But there are cons here. And like all the treatments, and this includes surgery, they don't cure the problem. So in fact, we do see regrowth of nasal polyps occur. And again, there are lots of different studies. We'll look at a few, but it can be a significant number by 1 to 2 years after surgery. It's important after patients have the surgery that in fact they keep on their intranasal corticosteroids to prevent regrowth. We know that if our patients have type 2 inflammation, those patients tend to have a higher rate of regrowth of the polyps. And again, there can be complications, as there can be with all surgeries. So we talked about standard of care, nasal irrigation, intranasal corticosteroids, a burst of oral corticosteroids. And from a study that comes from the Galen group, which is the Global Allergy and Asthma European Network of their ENT group, they found that about 46% of their patients failed, in fact, standard of care therapy and required surgery. Then there are several studies, and these are all out of Europe or the UK, that have looked at a recurrence rate and need for repeat surgery. So in fact, as we mentioned before, up to 40% of patients at 18 months will in fact have polyp reoccurrence. A very large study that was done out of Belgium showed that 33% of patients required repeat surgeries over a 12-year period. So a very long study, and 20% of those patients required multiple surgeries. So again, there is a failure rate also, unfortunately, in our patients, in fact, that do have sinus surgery. Now, another treatment that was also approved in 2017, and this is approved for patients that have already gone through a sinus surgery and have had recurrent nasal polyps, and that is using a corticosteroid eluding stent. It's approved of patients 18 years of age, again, who have already had sinus surgery. This uses mometasone as the steroid. It's placed directly in the ethmoid sinus and lasts there for about 90 days. The good news is this doesn't require surgery. It can be done in the office in an ENT clinic. And based on their phase 3 study, 300 patients that had had previous surgery and recurrent polyps, they were able to show significant improvement in nasal congestion with the use of the stent, and 61% of those did not require revision surgery. Next, we want to move on to our biologic treatment options. And I really like this, that comes to Euphoria, because it helps us as far as giving us a clear criteria of when to consider biologic treatment for our patients with nasal polyps. So one, obviously, you have to have bilateral nasal polyps. Unilateral usually means some other disease condition. And this is divided here whether the patients have already had surgery or not. If they've had surgery, they need 3 of the criteria. If they've not had surgery, 4. So evidence of type 2 inflammation, need for systemic corticosteroids, so 2 or more courses in the past year, significant impairment of quality of life and significant loss of smell, and a diagnosis of comorbid asthma. So if we look at this criteria for our patient Bob with no history of surgery, he definitely does fit the criteria for biologic treatment. So let's look at the different treatments that have been approved and emerging for chronic rhinosinusitis with nasal polyps. And we'll go in the order of approval by the FDA of the United States. So Dupilumab, which we know blocks the IL-4R alpha receptor subunit on many different cells involved in type 2 inflammation and blocks the activity of IL-4 and IL-13, has been approved by the FDA for add-on maintenance for adults with uncontrolled chronic rhinosinusitis with nasal polyps. It is given in a dose of 300 milligrams every 2 weeks sub-Q. Omalizumab, as we know, blocks IgE. It is approved by the FDA as add-on maintenance for adults with inadequate response to intranasal corticosteroids for nasal polyps. Now, its dosing is as done in asthma, which is related to the patient's serum IgE level, their total serum IgE level, and body weight. And therefore, the dosing could be anywhere from 75 to 600 milligrams every 2 to 4 weeks sub-Q. And then just recently approved by the FDA is mepolizumab, which we know blocks IL-5. It also has the same indication as omalizumab, add-on maintenance for adults with an adequate response to intranasal corticosteroids for nasal polyps, and it is dosed in 100 milligrams every 4 weeks subcutaneous. And so far, benzorilimab, in fact, which blocks the IL-5R alpha receptor, is in phase 3 studies at this time. So we will be looking in just a minute at the phase 3 trials of these biologics that you see on this slide. Now, in all of these trials, there are 2 co-primary endpoints. The first co-primary endpoint is the nasal polyp score. And you can see here it is scored from 0 to 4, 0 being no polyps on that side of the nose, all the way to 4, which is large polyps causing complete obstruction in the inferior nasal cavity. So, as you can see on the bottom, the right side had a 3 here, and the left side had a 3. So the total score, in fact, was 6. In general, for these studies that we'll be looking at, patients were enrolled in these studies if, in fact, they had nasal polyp scores of 5 or greater. So it gives you an idea of the degree of polyps that were done in these studies with biologics. And then the second co-primary endpoint in all of these studies is a severity score of nasal congestion. So the nasal congestion score, or CNS. And this focuses, again, on congestion obstruction over a 24-hour period from 0 being no symptoms to 3 being severe symptoms. Now, two of the studies that we'll talk about, Dupilumab and omalizumab, use 0 to 3. The mepolizumab study, in fact, used a 0 to 10 scale for nasal congestion score. So let's look at the phase 3 studies and the primary endpoints and others with these three biologics. First, we have Dupilumab. So these were two phase 3 clinical trials, the Nasal Polyps Sinus 24, where they either got Dupilumab or they got placebo. Now, the placebo group and the Dupilumab group also were on an intranasal corticosteroid. And then the Sinus 25 group, Sinus 52 group, these patients were either, again, placed on placebo or Dupilumab every 2 weeks. At 24 weeks, the group that was on Dupilumab have continued every 2 weeks, and the other group went to every 4 weeks with Dupilumab. Now, very importantly, and I'll give you these numbers for the other biologics in just a minute, is what was the improvement in nasal polyp score measured in points? In other words, what we know is that a 2-point or greater improvement is usually very clinically relevant for the patient as far as improving their nasal condition. So it was 46% with Dupilumab in the Sinus 24 and the Sinus 52 study versus 5% for placebo in Sinus 24 and 1% in placebo as far as Sinus 52. Also, if we look here, and that is the difference at week 24, which is the primary endpoint, between the placebo group and, in fact, the Dupilumab group as far as change in nasal polyp score. And for Sinus 24, in fact, it was 2.06 point improvement. Remember, it's an 8-point scale for the polyps. And for the Sinus 52, in fact, it was a 1.8 improvement. Again, all of these, in fact, were statistically significant. Now, if we look at nasal congestion and obstruction, in fact, in both Sinus 52 and Sinus 24, there was significant improvement. The nasal congestion score, remember, 0 to 3 was a minus 0.89 for Sinus 24 and 0.87 improvement in the Sinus 52. Also, and again, this is very important clinically, is what happens as far as the need for oral corticosteroid burst or surgery in these patients. So this is pooled data from Sinus 24 and Sinus 52, looking at patients either receiving oral corticosteroids or requiring surgery during the 52-week period. And you can see here, it was 41.8% of the placebo group, only 12.5% of the Dupilumab group, with a very significant p-value. What about safety? And again, we have a lot of safety with Dupilumab and other type 2 conditions. And again, this showed very high safety profile, with the most common treatment and emergent adverse event being nasal pharyngitis. In fact, a little bit higher in the placebo group than, in fact, the Dupilumab group. You'll also notice that for nasal polyps, you'll notice, again, because of the worsening, it was 12% in the placebo group, 3% in the Dupilumab group, and you see the same type of thing happening as far as asthma worsening. Now let's move on and talk about omalizumab. And again, omalizumab here, they had two phase 3 clinical trials. They were both 24 weeks, so there is no 52-week study here, and that was Polyp 1 and Polyp 2. Here we're looking at the nasal polyp score. And again, what percent had a 2-point improvement or greater? It was 31% of the patients that received omalizumab versus 11% on the placebo group. And then if we look at the difference at 24 weeks, what you'll notice here is the difference here was 1.14 for Polyp 1, and for Polyp 2, it was 0.59. So again, looking at the differences as far as response at 24 weeks with the use of omalizumab. Here is the nasal congestion score. And again, the difference here for Polyp 1 was 0.55, again, out of that 3-point scale. And for Polyp 2, in fact, it was 0.50. Again, if we look at safety related to omalizumab, omalizumab, as we know, has been around for over 15 years in the United States. And again, we see a very good safety profile here. The most common adverse event here, in fact, was asthma exacerbation in the placebo group versus omalizumab. And again, we see nasal pharyngitis in both the placebo and omalizumab group. And then the agent that was most recently approved by the FDA, Biologic, for the treatment of nasal polyps is in fact mepolizumab. This study, there's just one phase 3 trial, and it is a 52-week trial. So need to remember that. And what we're looking at here again is over on the left is looking at the nasal polyp score and looking at the degree of improvement. So if we look at 2-point improvement and greater, it was 26% with the mepolizumab group. It was 12% with the placebo group. So if we look at the adjusted means, the difference was 0.73 between mepolizumab and placebo as far as a nasal polyp score. And then if we look at obstruction over on the right, the difference here, remember, this was a 10-point scale. The difference was 3.14 in favor of mepolizumab. Also, what you can see here is mepolizumab looking at improvement as far as reducing the need for sinus surgery in this patient population. So in fact, if we look out at 52 weeks, which was the endpoint here, for the placebo group, about 23% required surgery, only 9% in the mepolizumab group, and in fact, you can see the statistical significance. Again, if we look at safety in their phase 3 SYNAPSE study, we see at the top there being nasal pharyngitis. You will notice that there was one resulting death, which in fact was a transient ischemic attack that occurred in the placebo group, and there was a myocardial infarction that occurred in the placebo group after treatment. So again, another very clean safety in the phase 3 study with mepolizumab. And again, as we've seen with the other biologics, you can see the worsening of asthma in the placebo group compared to mepolizumab, and also nasal polyps. So this brings us to choosing a biologic and shared decision making. So going back to the Euphoria guidelines, how do we select a biologic? And I think what's in the red here is very important, and that is predicting response in any individual patient is not yet possible. We don't really know which will work better in which particular patient at this particular time. So we need to confirm the diagnosis of uncontrolled severe chronic rhinosinusitis with nasal polyps, check for comorbidities that we've talked about, check to see if the patient does have type 2 inflammation, inform the patient on all the different treatment options, perspectives, and risk, make a decision on surgery or biologic, again, with an informed patient, and then select a biologic. And it states here no limitations applicable to specific drugs. But I think for the 3 biologics approved so far in the United States, the indications are basically around the same. Now, we choose a biologic. So how do we assess the patient? So what they're suggesting here is that we assess the patient after 6 months of treatment. And what we're looking for here is improvement of at least one symptom or score. So improvement of things like sense of smell, or nasal congestion score, or nasal polyp score, or if we do use the SNOT-22. And what is used in many cases is a visual analog scale total symptoms. So just asking the patient on a 10-point scale, where do they fall from 0 being no symptoms to 10 being severe symptoms, and looking for at least a 2-point improvement. So if the answer there is yes, they have improvement at least one of these symptoms, then we ask, is this acceptable to the patient? Do they feel like they're doing well? In which case, we continue them on that biologic therapy. What if they say they're improved, but it's just not acceptable? They're just still not feeling well enough. Then it suggests the possibility of an additional short course of oral corticosteroids or to do surgery under biologic protection. If the answer is no after 6 months, then the suggestion is to change to surgery or another biologic drug. What about after 12 months? Well, by 12 months, we really should see adequate response in all the major criteria. So nasal polyp score, nasal congestion score, visual analog scale, SNOT-22, and the patient shouldn't currently need any oral corticosteroids or surgery. So if they answer that yes, we continue them on the biologic treatment because, again, the biologic treatment does not cure the condition. But if the answer is no, we have two choices. One, surgical procedure. Two, consider one of the other biologic therapies. So this gets to shared decision making. What I put together here is just some situations that you may see in the clinic situation related to patients with nasal polyps. So you have a patient that's failed standard of care therapy. So generally we talk about shared decision making between a biologic or the fluticasone breath-powered exhalation device or a surgical procedure. What if they've had failure of their first surgical procedure with or without the use of a corticosteroid stent? Well, we could still talk about biologic or placing a steroid stent or a repeat surgical procedure. And in fact, we could say the same thing if the patient has had 2 or more surgical procedures. Again, you still have the option of biologic, a stent, or repeat surgery. And what about patients with failure of treatment as far as standard of care, and they have significant type 2 asthma, like our patient population, like our patient Bob that we talked about, or they have other type 2 comorbidities? Then I think in general, we're probably talking more about a shared decision making between a biologic and a surgical procedure. So this comes to us, and this has been modified from a shared decision-making tool developed by the American College of Allergy, Asthma, Immunology and the American Rhinologic Society. And these tools, in fact, are on both organizations' websites. And again, giving patients information in a way that they can understand related to the different treatments. So how are they used? What are the different pros? What are the different cons? And very importantly, what are the costs associated with each particular treatment, especially for that particular patient. So we're going to go back to Bob here. So we've talked about him having uncontrolled severe chronic rhinosinusitis with nasal polyps with an asthma comorbidity. So in shared decision making and talking with him, we talk about endoscopic sinus surgery. We talk about the different biologics that are approved. So kind of talking with Bob, surgery was not really a great option for him at this time. He was worried about the amount of time he'd missed from work. He was interested in the biologics. So Dupilumab has the longest track record as far as approval in the United States with dosing every other week. Omalizumab for him maybe every 2 to 4 weeks, depending on what his serum IgE level is and body weight. And then mepolizumab, which was just recently approved, but has a dosing, in fact, of every 4 weeks. So there is no right or wrong. And again, with shared decision making, we all come together, the patient and the clinician, determine what would be the next best step for the patient. So in summary, chronic rhinosinusitis with nasal polyps, as we know, is a highly prevalent condition, makes up about 20% of all our patients with chronic rhinosinusitis. We know that there are significant comorbidities with this condition: asthma, allergic rhinitis, aspirin or NSAID exacerbated respiratory disease. As we talked about, primarily in our patient population, chronic rhinosinusitis with nasal polyps is driven by type 2 inflammation in those type 2 cytokines, IL-4, IL-5, and IL-13. As we mentioned, unfortunately, standard of care management in many cases gives a short-term response, and we do see a failure rate. We know that surgery, in fact, can be successful, but unfortunately, there still can be recurrence of nasal polyps. And we now have 3 biologics approved in the United States for patients with chronic rhinosinusitis with nasal polyps. I think it's very important to use shared decision making to get a personalized selection. And again, we need to understand the values and the preferences and the goals of the patient. Here, very importantly, dosing preference and also ability to pay insurance obviously plays a key role. So with that, we're going to move on now into our post-test questioning. So come back. The primary cytokines involved in type 2 inflammation, the most common endotype in patients with chronic rhinosinusitis nasal polyps are, as you can see here again, interferon gamma and IL-12, TNF alpha and IL-6, IL-4, IL-13, IL-5, and IL-17 and IL-22. And as we see here, we definitely have a change from the pre-test to the post-test. And in fact, everyone has got this right now, that in fact, the three type 2 cytokines, as we talked about, the primary roles of IL-4, IL-13, and IL-5. So very important. Now, our second post-test question. Which biologic showed improvement in nasal polyp score by 2 points or greater in close to half the patient population at weeks 24 and 52? Okay. So we see kind of a mixture here with omalizumab being the largest number. But in fact, the answer is Dupilumab. So with Dupilumab, there was a 46% of the patients in both 24 weeks and 52 weeks had a 2-point or greater improvement in nasal polyp score out of that 8. For omalizumab, if you remember, it was 31% versus 11% with polyps. And then mepolizumab, in fact, was 26% with a 12% improvement in the placebo group. Now, again, these were not head-to-head studies as such. And I think that's important to remember. But it does kind of give us at least a general overview as far as the amount of response, at least in those particular patient populations. Okay, our next question. Which is the most commonly observed treatment-emergent adverse event across the clinical trials of all biologics studied for chronic rhinosinusitis with nasal polyps? Is it epistaxis, injection site reaction, nasal pharyngitis, or abdominal pain? And we can see here that, again, it was in fact a nasal pharyngitis, was in fact the most common. Again, we do see, because all of these are given by subcutaneous injection, you do see injection site reactions, but it's very interesting. Again, the most common seen was the nasal pharyngitis. Now we'll get to our last two questions related to Mr. Brown here. Mr. Brown is a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps. He returns 12 months after endoscopic sinus surgery complaining of persistent symptoms. You suspect nasal polyps have regrown, as type 2 inflammation is a predictor of polyp return in greater than 50% of cases. Now, the disease scoring system shows some improvement, but do not meet the euphoria criteria for inadequate response. What does euphoria recommend now? Is it return to medical management and short course of oral corticosteroids, biologic drug or revision surgery, exhalation delivery device system with fluticasone, or a corticosteroid eluding implant stent? And here, again, we got 100% correct here, or almost 100%, and that, in fact, is a biologic drug or revision surgery if we follow the recent euphoria guidelines. And then our last question related to Mr. Brown, he's feeling discouraged. He says his nasal polyps are just going to grow back anyway. He doesn't want to go through the expense, pain, downtime of undergoing surgery again. Shared decision-making means the best action now would be to advise him to consider surgery, because 30% of patients do require repeat surgery. Appraise him with the guidelines recommend, and ask him to decide between the two options. Give him information about all available biologics, ask him to choose one, and let him know all the therapeutic options, the pros and cons of each. And in fact, yes, everyone's got that right. It is the bottom. And that is, it's very important that the patients understand on a level that they can understand the pros, cons, cost, and we have to understand their values and preferences as far as determining the next step as far as their management. So with that, we'll now go to our question and answer session. I'm waiting to see if any questions come up. Okay. So first one comes up, what are some reasons patients give you for choosing a biologic over surgery or vice versa? And I think very importantly here is that, again, there's definitely a group of patients that just do not want a surgical procedure, especially because it doesn't cure the condition. They still have to go on intranasal corticosteroids to, in fact, control their problem. So I think in many cases, when you explain that to the patient, that in fact they may opt out of doing a functional endoscopic sinus surgery. And therefore, in many cases, will want to go with something that works better than the intranasal corticosteroids that they have been using, and therefore, in many cases, will choose to use a biologic and see, in fact, how they do in those particular cases. And again, following the Euphoria guidelines, we can keep assessing the patient at 6 and 12 months and determining where we go from there. So I thought IgE was another question here. I thought serum IgE was supposed to be the biggest reason to use omalizumab. Well, the bottom line here is we know that IgE, in fact, as we went through type 2 inflammation, is involved in type 2 inflammation. But as far as the exact complete mechanism of action related to omalizumab and its effect on nasal polyps, in fact, we don't have the answer at this particular time. So it's having some effect on the type 2 inflammation pathway, which is helping to decrease size of nasal polyps. But unfortunately, the exact mechanism of action of blocking IgE, if that is the mechanism of action of omalizumab and nasal polyps, we're just not clear at this time. We know that there is a high local production of IgE to Staph aureus, so that may also be playing a role here as far as the activity of omalizumab. And should we be measuring levels? Next question. Should we be measuring levels of IL-4, IL-13, or other cytokines before deciding on treatment? Well, in general, the answer is no, because in fact, they're not easy to measure. They're not easy to get a typical blood study and measure levels of cytokines. We do know that in general, patients with type 2 inflammation do tend to have higher levels of blood eosinophils and tend to have higher levels of serum IgE. But I think if we look at the package insert for all three biologics, we're not required to do those types of things to determine, in fact, if the patient will respond to the particular biologic. So I think at this point in time, measuring levels like IL-4, IL-13, and the others is not something that is done in clinical practice. And then one more question here. Why was it important to measure FEV1 and exhaled nitric oxide in the patient case? Well, I think it's very important as far as knowing their lung function and again, the degree of airway inflammation by looking at exhaled nitric oxide. And it gives us an idea of how well his asthma is under control. And if we've got a patient that has poor asthma control, especially on high-dose inhaled corticosteroids, long-acting biologics like long-acting bronchodilators like Bob, and they also have nasal polyps, then and this is a case where, in fact, and something we could talk to Bob about, is that a biologic, can do very well as far as treating both of these conditions. Because as we know, all three of these biologics, in fact, are approved for, in fact, the treatment of severe uncontrolled asthma. So that's why I think not only knowing his sinus disease, knowing and doing endoscopy, doing CT scan, but his lung function is very important as far as treating all of Bob and not just his nasal polyps. So I think what we'll go on to, it looks like we have one more question here. I know we're at the top of the hour. How do you advise chronic rhinosinusitis with nasal polyp patients who are interested in biologic therapies but are reluctant because of cost? Well, I think one is we have to find out, related to what health plan they're on, what exactly would be the cost associated with the particular biologic to really make that answer. So I think what we have to do is go through their insurance company or Medicare or Medicaid and see exactly, again, what would be the cost issue associated for them. We know that all of these companies have assistance programs, so the patient may also qualify for one of the assistance programs. So with that, I want to thank you for joining me today. Hopefully you found this informative and help you in managing your patients with chronic rhinosinusitis with nasal polyps. For additional resources and information related to this subject, as you can see here, you can go to integrityce.com/CRSwNP or chronic rhinosinusitis nasal polyp resources. And now you're going to be redirected to an evaluation and also to be able to get your CME. Or later on, you can claim your CME credits by going to integrityce.com/chronic rhinosinusitis with nasal polyps post-eval 1. Again,